Hi, and welcome to the Adult Neurological Disorders module. Today, we're going to talk about adult neurological disorders, what kinds of things you might come across, and how you may be able to manage them. The first thing to consider with any neurological referral is this: is the disorder stable or is it neurodegenerative? These are two vastly different categories. Stable neurological disorders, like a past stroke, cerebral palsy, or a traumatic brain injury, are relatively steady over time, and our focus with these referrals is on seeing gains and improvements, especially within the first 2 years of diagnosis, which is the window of greatest plasticity. In contrast, neurodegenerative conditions, such as motor neuron disease, Parkinson's, MS, or progressive supranuclear palsy, show deteriorating function over time. Here, our focus shifts to maintaining the current function, setting small, specific functional goals, and proactive forward planning to manage and mitigate future decline. When completing your initial assessment for any neurological referral, you first need to establish a clear baseline across 3 critical domains. Firstly, complete a comprehensive oral motor evaluation. This is really vital for tracking subtle changes in speech and swallowing, especially with neurodegenerative conditions. Second, we need to conduct a thorough swallow assessment or bedside evaluation to determine what the client's current level of function is and if an instrumental assessment, like a FEES or a video fluoroscopy, is required. Finally, we need to consider doing a suitable language, speech, or voice screener to fully characterise any underlying communication challenges that the client may have. When planning intervention for clients with neuro conditions, 3 key areas need to guide your approach. First, everything hinges on the client's diagnosis, their prognosis, whether the condition's stable or degenerative, and the goals that have been revealed by your assessment. Secondly, it's really important when you're considering any neuro client that you need to know a bit about your functional anatomy and physiology. This knowledge is essential for interpreting medical reports, such as infarct locations, to anticipate the client's challenges and to properly guide your treatment. Finally, for intervention, remember that when working with clients with neurological conditions, we work with a marathon analogy. If you want to run a marathon, you don't just get up out of bed one morning, show up at the start line, and expect to achieve that 42-kilometre run. You need to train, you need to build up strength, and you're going to have to practice over and over again to build up to that 42 Ks. Clients often have huge goals, but our role as speech pathologists is to break the process down. We need to help them focus on small, functional steps, like ordering a coffee or making an appointment on the phone, which are the building blocks to bigger, more meaningful progress over time. When working with clients with neurological conditions, we need to remember a number of key principles. Firstly, and fundamentally, you need to know your functional anatomy and physiology. If you're ever unsure, look it up, as this knowledge is essential for every client you're going to see. Secondly, you need to plan and create functional goals using that marathon analogy. Clients will present with huge goals. We need to break them down so they can consistently see success. And finally, we need to educate. Educate, educate, educate. Neuro conditions are lifelong, and we are there to communicate realistic expectations, to provide support through the inevitable decline in neuro conditions, and to help put proactive procedures and practices in place to work around those challenges. When working with neuro clients, we need to approach them with a holistic, big picture mindset, guided by these questions: what, where, and why? What is the client's diagnosis? What's their prognosis? And what's the specific symptom they're facing? Where's the breakdown occurring? Is it a voice issue, a swallowing issue, or is it a breakdown in oral motor function or speech sound production like apraxia? And finally, why is this happening? What's the anatomy and physiology behind it? And what are the crucial contributing factors like cognition, environmental supports, and social supports that may be impacting it? Never forget, neuro clients are not cookie cutter, so we always need to think outside the box to deliver truly individualised care. When considering a neurological referral, you first need to determine if the condition is stable or degenerative. I've said this a lot, but it's so important as it dictates the potential prognosis and treatment goals that you will set. Stable conditions, such as a previous stroke, may allow for more improvements due to neuroplasticity, with the primary goal being functional gains over time. In contrast, degenerative conditions like MS or Parkinson's will have a poorer prognosis, and they carry an expectation of future functional decline. Therefore, we need to shift our focus to communication maintenance and proactive future planning rather than rehabilitation. Regardless of the diagnosis, a thorough assessment of the client's swallow function is mandatory. While a bedside evaluation is often sufficient, you do need to refer for an instrumental assessment if a client is particularly challenging, if they don't respond to a texture-modified diet in a typical way, or before you begin any rehabilitative swallowing or vocal exercises. Finally, remember that an instrumental assessment is a non-negotiable step before considering any referral for enteral feeding. Moving on, we're going to consider a case study for Stephen, an 82-year-old man who was diagnosed with Alzheimer's dementia 5 years ago. He lives with his wife, who's his primary carer, and also has some support from his 2 adult children. Stephen is no longer able to communicate verbally, and he's become very withdrawn, now spending most of his time in bed. But he will still use some non-verbal communication with his family, such as smiling. He requires a manual assist wheelchair for all mobility, but he frequently forgets this and tries to walk independently, resulting in significant falls. He also needs full assistance with all activities of daily living, and he can be resistant to care. Critically, his wife has reported new mealtime challenges, coughing when drinking thin fluids, refusing to wear his dentures, and rejecting many foods he used to enjoy. He's also having difficulty feeding himself, but becomes distressed or agitated when his family tries to assist, and all his meals are now taking place in bed. Based on the case study information, here's a breakdown of Stephen's situation. We know the following facts. We know his diagnosis is progressive Alzheimer's disease. His prognosis is poor, with an expectation of continued cognitive decline over time. We know about his social supports, predominantly his wife and his adult children, and we also know about his physical state in that he requires a manual assist wheelchair, he spends most of his time in bed, and he's currently unable to feed himself independently. Some of the challenges that come along with this include behavioural challenges and resistance to support with both activities of daily living and mealtimes. He also has challenges with his safety and mobility, which are compromised by his tendency to forget his physical limitations and attempt to walk independently, and significant social decline, with Stephen having become very withdrawn, no longer communicating verbally, and being very resistant to external supports coming into the home. So what are our goals? Our immediate goal will be to address the root cause of his difficulty at mealtimes to ensure that he's safe to eat and he's getting an adequate intake for his nutrition and hydration needs. In the long term, though, our focus will move to implementing proactive forward planning to manage and mitigate the future decline associated with his neurodegenerative condition. Crucially, we also need to support his family by providing them the necessary education and resources to help them manage the condition's progression. So where do we start? Our plan for Stephen's care centres on a number of key areas. Firstly, we need to begin with a bedside swallowing evaluation to assess his current diet, to determine if we need to modify his food and fluids further, and to find ways to encourage him to accept assistance. We might consider trialling the use of a separate set of cutlery for him, for example. A crucial environmental change will be to move his meals to be taken out of bed, which is obviously the safest option to reduce the risk of aspiration and pneumonia. If this is not possible, we will need to ensure that he's sitting upright and well supported if he cannot move. We'll also look into social supports to give his wife a break and to encourage Stephen to engage more readily with external support workers. The most impactful long-term action, though, will be to provide comprehensive education for his wife and children about the likely progression of his Alzheimer's, particularly with the expected decline in his swallowing. This will involve teaching them the safest feeding techniques, educating them on the signs to look out for, and proactively discussing future planning, including connecting them with support coordinators or other agencies if they're not already connected. We need to plan now for the likely further degeneration of Stephen's swallowing over time to ensure that his family is equipped to provide the best possible support for him between speech pathology sessions. If you're looking for additional support or resources for assessment and intervention of neurological disorders, we have a range of resources available on the Concentric Hub, the Template Gallery, and the Google Drive. These include, but aren't limited to, materials on AAC for adults with acquired neurological conditions, the Mann assessment of swallowing, information about neurogenic communication disorders, the Quality of Life in Swallow Disorder survey, and an introductory video about EMST. The main takeaway, though, is this: please access and educate yourself on these resources as much as possible. Having a strong foundational understanding will be your biggest factor in being able to best support your clients with neurological disorders. But of course, if you have any questions, please reach out to your clinical mentor or ask for a clinical consultancy session to support your ongoing learning. If you still have questions, remember there's no such thing as a dumb question. Never be afraid to ask for help, as we have a great support team ready for you. You can speak to your clinical mentor with all your questions, and if they don't have the answers straight away, they'll find them. Also, remember to ask your colleagues for assistance and advice. You can complete shadow sessions with your mentor. You can also ask for clinical consultancy sessions to further expand your knowledge of assessment and therapy planning. Neuro clients can be challenging, but they're also incredibly rewarding. So always reach out. We're here to help you succeed.